Yay Networks.
Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and in today's episode, we're going to be talking about pediatric plastic surgery. Now, that doesn't mean you're going to have your little one going to have a tummy tuck. It's not about, rhinoplasty on your infant. It's about all the critical elements of pediatric plastic surgeries, such as cleft lips and palates, kids born with ear deformities, people with nevi or huge moles, strawberry hemangiomas, and much, much more. So you're definitely going to want to tune in. We're actually honored to have Dr. Andre Panossian, who is world-renowned pediatric plastic surgeon. Andre?
Hello.
Let's see, where can we start? First and foremost, I've known Andre now for 20 years, Andre? Something
20,
on the order.
Yeah, I think so. 21 years.
20 years. Yeah. Andre and I actually did our training together at USC. And so that's when the love affair started. Misery Loves Company. And so we created a very strong bond. And Andre went on to specialize and subspecialize and subspecialize in a host of super complicated but very, very important areas of pediatric plastic surgery. So today's topic is pediatric plastic surgery. It's a little off topic from what we normally talk about, which is in the realm of aesthetics, but I think it's incredibly valuable for a number of reasons. Number one, I think it tells everybody how diverse and amazing plastic surgery is. We train to do a lot of things: breast cancer, burn, craniofacial, et cetera, and it's an honor to have somebody who does this on a day-to-day basis. And the second is, you never know when your life is going to take a turn. You never know when you're going to give birth to a child and all of a sudden you're now faced with this incredible, you're overwhelmed with this new diagnosis, and God willing you don't, but if you do, you're going to want to know where to go. So Andre and I did our training at USC. We did our plastic surgery residency / fellowship. And then Andre, you went on to do what other subspecializations?
I chose to focus on kids, something called craniofacial surgery, which is a fancy sort of a title for someone who deals with kids, because a lot of what kids have to deal with birth deformities of the face and the head. And therefore, it sort of falls under that umbrella. So I did a year of that, and then I went and did another half year of another type of subspecialization at another institution, where we focused in on a very small subset of deformities that kids can have, and they're related to a series of tumors and what we call vascular malformations. And I spent another 6 months doing that on the East Coast before moving back to Los Angeles. So that's sort of the background where I come from.
Right. So for any of you who have no idea what he's talking about, bottom line is Andre knows everything there is to know about kids and the deformities that children are born with. And the areas in general are what we all know and most people are common with: cleft lips and cleft palates, which we're going to dive into because I think that's not only one of the more frequent deformities, but is the one that people are most familiar with. But then there are a lot of sub areas, like we talk about facial reanimation, which are kids that are born with paralysis of their face, whether that be congenital or sometimes traumatic. We're going to talk a little about a few esoteric but really important things like nevi, or basically humongous moles, neurofibromatosis, which is a very rare condition as well. We talk about vascular malformations, and these subject matters are all really important because, God forbid, if you're one of the people whose family is affected by it, it could be your niece, it could be your nephew, it could be your grandson, it could be your own children. You're going to want to know, and I think nothing better than having Andre on. So let's dive in, Andre. So every time, let's back up here. You and I have done many a mission. By mission, meaning volunteer missions to different countries. We've done, we did El Salvador, we did Paraguay, we did Armenia, we did Haiti. So we did these missions, and of course I naturally went on them because I was accompanied by you, and so I always felt like I had an expert with me. And amongst the many things we dealt with a lot of cleft lip and palate. So let's start out by defining things. Can you give us an explanation of just the basics of happens to a child who develops a cleft lip and then also a cleft palate?
So the field of cleft lip and palate deformities is a little bit broad. It's not just one type of deformity. There's variations. It's a spectrum of deformities. It's not necessarily genetic in nature. In other words, it's not necessarily passed along. And you do not necessarily have the ability to pass it along to another generation of your offspring. So what it is that when the face forms in the womb, there's a certain period of time in which the certain embryonic, or these are the tissues of the fetus, have to fuse together to form the face. One of the fusion points happens to be where the lip lies. So it could be where those columns are, what we call the philtrum, those linear columns. That is a fusion point. And so when it doesn't fuse, you get a cleft lip. Now the cleft lip can go all the way back into the palate, all the way back and into where the uvula is, and that will essentially give you the cleft palate as well as the cleft lip. So you can have a cleft lip without a cleft palate, or a cleft palate without a cleft lip. Or you can see the more common thing, which is a cleft lip and palate together. And so we see that, and of course kids are born with that, and it's a very big deal for parents when they see it, and they're sort of distraught by it, and in some cases is picked up in utero with ultrasound exams. So there's a little bit of preparation that goes into it, but the state of the art is fantastic for people with cleft lip and palate. There's excellent technical refinements in repairing the deformity of the lip. It's done very early in life. In the first 2 to 3 months of life, you can get that repaired, sometimes even in the first month of life.
Yeah, so let's back up here for a second, because I like to kind of reiterate things. So basically the left side and the right side of your face, which there's no left and right because it's all relative, but let's just say for the sake of this argument, come together and basically create a seam in the middle, and they come together and they form your face. And so what essentially what's happening is, when the fusion comes together, if there is a deformity in that fusion, there's a separation or a gap, which then we refer to as a cleft. And that cleft can occur in the lip, in the palate, in the eye, in the eyebrow, etc., but very commonly in the lip and the palate. And as you had described, there's various degrees of it. So naturally, what's the problem with it? So the problem with it, of course, is aesthetic, but there's a lot of functional issues, right? And so tell me what some of the issues that children will have if they don't fix this cleft lip and palate, other than the fact that it's incredibly unsightly for a parent to see.
So it is, as you've pointed out, it isn't just a cosmetic deformity. Obviously, the lip has a function. First of all, it is a circular sphincter. In other words, the lip is similar to the eyelids in that it cinches together and forms what's called a purse string effect, so that you can pucker. Well, that puckering function is not the only thing that muscle does. It can allow you to articulate when you speak, so that you can be understood. That's one thing. Second of all, in young children, it actually produces that suck phenomenon, so that they can use a normal bottle, and initiate a suction or a negative pressure inside their mouths. So when the lip is discontinuous, or it has a cleft in it, then that muscle doesn't meet at the cleft, and therefore you get an inefficient ability to work the lips. And so repairing that muscle also helps with speech, with feeding, with even swallowing to some degree.
And the palate, of course, communicates and allows people, the uvula and the palate, where you enunciate and close down and can say certain letters. And so it's very, very important. And then, so obviously the goal of, we're not going to get into the technical details of it, but the goal is to repair them, and repair them as quickly as you can before speech and development occur. So the number one question I hear, and I'm sure you're going to echo this when I come back from these missions, is why are there so many of these in these other countries? Why are there so many of these in other countries? So what's the answer to that?
Well, it's a difficult and a complex answer to it. It's not because they're more, let's just say, genetically prone, since I just sort of mentioned that it's not necessarily a genetic condition. It's what we call a multifactorial condition. In other words, multiple things during the development of the human body inside the mother's womb can go wrong, where that event can happen at a critical point in the development of these babies. And so when things like, alcohol use happens, or, cigarette smoking, or iron deficiency, and there's a whole host of what we call multifactorial or environmental things that can affect that moment in time. So it's an inability to say, oh, it's just this one thing. So we believe that maybe it's a nutritional component in these other third world countries where they don't seek prenatal care in an efficient way. So they don't know how to balance some of these external factors that might create a cleft lip and palate deformity. There could be some consanguinity thing going on as well. We don't know exactly why that happens more frequently, but in other words, to very focus that reasoning to why it happens is a very difficult one to give you. We just know that here in the United States, it can happen as well, because we do have people who are socioeconomically disadvantaged and don't seek maternal health, prenatal care.
So Andre,
Let
me ask you a question. So let's just start out with the basics, because my understanding is a little bit as follows. I mean, the overall rate of cleft lip and palate is around 1%, if I'm not mistaken. What's the numerics, right?
It's actually even less than that. It's about 1 in 700.
Okay, so let's say it's 1 in 700. It turns out that in other countries, it's not so much different, which then tells you a certain kind of thing, whether it's because you're malnutrition, whether you got really unlucky and you had a sporadic mutation. Mm-hmm. The reality of it is that it's not that much more common in Guatemala than it is in Chicago.
Correct.
The reason why it's such a big deal is in America, when a child is born with a cleft lip or palate in the hospital, when do they get it repaired? When do you get your lip and palate repaired in America, Andre?
Roughly at about a month of age.
A month. Yeah. So do you go to
3 months? Yeah.
1 to 3 months. So the bottom line is, as a lay person, when was the last time you saw an American child in the supermarket at 2 years old with a cleft lip? Never. You just don't see it. Now, in Guatemala, in El Salvador, you're going to see 2-year-olds, 4-year-olds, 12-year-olds. And it's not because they get more of it. It's just they haven't been repaired because they're in the middle of some town where nobody does it. They don't have the means, the money, or the access. And so the answer to the question, the real answer, is it's not that there's more of it. You just see it later on. And in America, it's fixed and nipped in the bud. And you're Joaquin Phoenix. I mean, that's just what happens. You're a grown adult with a little scar down your lip, because the earlier it gets repaired, the better it looks. And so I think that's really the question, the main thing, because people come back to me always and like, oh my God, these poor countries. And they assume it's like in the water.
Right.
It's not in the water. It's just like, of course, they don't have prenatals, but that's not even the real cause of it. It's just that people aren't getting fixed. So you and I have done a bunch of these missions together, which I'll have you on at another time, and we'll do a mission trip about what is a mission, how does it work, how's it organized, who funds it, etc. But we're going to go into, now let's shift gears for a moment here. We're going to touch on just a few other topics, and then we'll take a break. So the other areas so cleft lip and palate is really a big area in craniofacial, but there are a few other things that people do. Number one is ear deformities. People are born without an ear, partial ear, without a canal, without the lobe, etc. What are those called, Andre?
Those are basically called microtia. So microtia is a underdeveloped ear or an absent ear. So those can happen all the way up to the most basic version, which is just a small ear, can happen. But yeah, those are a series of, again, another spectrum of conditions that are not necessarily genetic in nature, and they need to be repaired in kids so that they can interact and not have these social stigmas attached to them.
Right. So basically what we're talking about here is that a certain percentage of individuals, when they develop, during the development, which is incredible that as many people are developed normally as they are. I mean, like, let's just say a chain reaction of like 1 million things have to happen in occurrence for things to be normal. They develop this ear deformity, and the ear deformity starts from as mild as Andre said, which is, wow, your right ear looks a little smaller than your left ear, all the way down to no ear and deafness. I mean, you just have no ear, and you can't hear anything on that side.
And no canal either sometimes.
Right. No. So that's the spectrum. And Andre participates in a host of ways to reconstruct the ear, whether that be partially or completely. And give me just a general gist of the ways in which we repair ears in children, the categories.
So there's various categories that describe the developmental severity of that ear. So if it's a small ear or part of it's absent, it's got a little bit of cartilage, it's got a hole for the sound to go through. All these will be sort of what we call a Tanzer stage, and therefore there's different stages with different severities. So depending on from little bit of an ear to no ear, we do reconstructive surgery to rebuild that ear. Usually, when we have a case of microtia, we're rebuilding the whole thing. The whole cartilage framework is being rebuilt. Now, there's two flavors of rebuilding the ear. One, which is the traditional way, is to use the patient's own rib cartilage. There's lots of it. We usually have to do that when kids are about 9 or 10 years old to have enough rib cartilage to build that ear. The other way to do it is to use an artificial implant, a sort of a medically manufactured plastic, if you will.
Like a prosthesis.
Prosthesis, but it's an internal prosthesis and is covered by the patient's own tissues. And of course, the third way is a prosthesis itself. So the entire form of the ear, the skin, the color, everything is attached by magnets to the side of the head where the ear would sit.
When you have an ear deformity, let's say it's partial or complete, the ways to reconstruct the ear are one of three general ways. One is to just use a prosthetic, like an eyeball or prosthetic. And today the prosthetics are unbelievable.
Amazing. Yeah.
Arguably the best. In other words,
yeah.
The only downside is that it obviously detaches. And so for people who want it attached to their body, it's frustrating. But as far as look, nothing can beat it. The second is to go and take cartilage from the rib and physically sit there and make the ear, like carving it out of a bar of soap. Pieces, parts, suturing it, creating it. And the third is to use a material, the names are like Medpor, et cetera, et cetera. You put this material down that's a prosthetic, and then you cover it up with some tissue. So again, super complicated, super interesting, and incredibly valuable. And the reason why pediatric plastic surgery is so important, of course it affects your child, you'll understand, is that these things that are just ears and lips, they not only affects function, but the ostracization of a child for having, your child gets bullied because their ears are too large, let alone if you have all these deformities. So it's incredible, the ripple effect of the work that Andre does, because you'll see a 25-year-old and what he had done when he was 3 or 4 will affect every aspect of his psyche. So we're going to talk about one more topic and then we'll take a break. And the topic we're going to talk about is nevi. So nevi, what is it? A nevi is a mole, essentially, right? You have an area that's pigmented like a regular mole, and the word nevi represents mole. But we're not talking about your garden variety mole, are we, Andre? What kind of moles, what kind of nevi are we talking about in your instance?
So there's obviously various flavors of nevi. Most people don't even realize that, the little birthmarks, they don't even think about removing them necessarily. But the ones we're talking about are large ones, the ones that you cannot conceal, the ones that are too conspicuous, where you just sort of trying to focus in on your work and someone is just focused in on your mole. And that's sort of the degree to which these moles or nevi can get before you escalate the level of reconstruction. Obviously, a little tiny mole that you remove is not going to be that hard, but something bigger requires a little bit more effort.
So let's talk about nevi. Where are they? Like, we're talking about like on your whole forearm, on your arm, on your thigh. Where are the nevi in general? These big, and where are they and how big are they? Like, so that people can understand.
So nevi could be, first of all, they could occur everywhere on the body, from underneath the hair of the scalp to underneath the fingernails, all the way to every part of that is covered by skin. You can have small ones, like we mentioned. You can have slightly bigger ones, or you can have an entire torso covered with a big giant nevus, and we call that a giant nevus. And so those, obviously, the bigger they get, the harder the reconstruction is for something to that degree. So it could occur everywhere, and it comes in all sizes.
Right. And so the ones we're talking about here, and the purpose of the dialogue, is you have a child who's born otherwise normal, and they have, and let's say they're, white, whatever, and then they have this brown, ginormous skin discoloration on their entire left shoulder and onto their back. I'm talking humongous. And so there's essentially, if my understanding is correct, there's two major concerns. One of them, of course, is the aesthetic, and the other is all moles in general have semi-different cells in them. They're not regular cells, and these cells have a slight predisposition towards becoming malignant or, cancerous, like a melanoma. And the bigger the mole, the more of them there are, and the higher slightly that risk is. Correct, Andre?
That is correct. Yeah, we don't know the exact incidence of, let's say, a melanoma developing inside a big giant birthmark or even a tiny one. So what we're really trying to do mostly when we're trying to reconstruct and remove these moles or nevi is to basically get a cosmetic improvement in those areas. We have very little ability in the bigger these birthmarks get to totally eliminate the risk of melanoma and other types of skin cancers that can be related to it. So we don't try to necessarily knock it out of the park sometimes, but to reduce the areas that are more exposed to the public so that the child cannot have this social stigma and just this focus of attention on them that makes them uncomfortable, that leads to developmental issues and just socialization issues. So that sort of encapsulates why we try to remove it. But yes, we do get some theoretical reduction in the risk of things like melanoma as well.
Right. And then basically the way we remove them, unfortunately, it's very rudimentary. There's only if I'm not mistaken, only 3 ways to so-called remove them. And they're all kind of 6 of one, half of the other. You're kind of exchanging one lesser of two evils. One is to cut it out. If it's small enough, you can cut the whole thing out and you'll be left with a scar. The other is to cut it out and use your own tissue by a flap or a skin graft or something, which you're left with a scar and something else. And the last is try to use some of the lasers that we have to reduce the burden. And I know that that's still, if I'm not mistaken, the laser treatment is still not as effective as we'd like. Right, Andre?
That's correct. Yeah. Lasers, I think there's a sort of a misrepresentation about lasers in the public right now that they can handle anything, any blemish on the skin. And that's just an impossibility.
You can't get rid of my wrinkles, fix my big nose, and make my ears smaller with a laser? I mean, what kind of plastic surgeon are you?
Yeah. The thought process is that these lasers can do these things, these magical things, and unfortunately they cannot. Lasers work on the basis of color contrast, where you have white skin next to a dark something, whether it's a birthmark, a typical birthmark, or what we call a vascular birthmark, which is a little red or pink. And there's different levels of how effective that might be.
Lasers are just a scam. I mean, I'd say that broadly.
It's a huge scam. People waste so much money going back again and again. And of course, it's a money maker for people who are out there who have this laser and they're just wanding over everything that they see. And they'll keep people coming back without the promise of improvement.
I have many episodes talking about lasers. All right, so let's take a break because people need to chew and digest some of this information, because obviously this is a little more clinical, not as we're not talking about celebrity makeovers, but very, very valuable information. When we come back, we're going to touch on a few other of these unique, rare, but incredibly important birth defects or child abnormalities with Dr. Andre Panossian. So make sure to tune back after this break. Welcome back to the second half of Plastic Surgery Uncensored. I'm here with Dr. Andre Panossian, who is an expert in pediatric plastic surgery, and we've been chatting about some of these, albeit rare, but not rare in the fact that we have 7 billion people. So when you have something that's rare in 7 billion people, it's a lot. And so we chatted on some of them, of those elements, and we're going to kind of dive into another few of these items. One of them is the area of vascular malformations, which basically means malformation, it didn't develop correctly, vascular having to do with the blood supply. And there are two quite common ones that are actually, you can tell me the percentages of each of these, and obviously we don't know the exact numbers. One of them is something called the hemangioma, which the lay public refer to as a strawberry hemangioma. It's this really red ball, beefy thing that's on children. And the other is a venous malformation, which is kind of a bluish hue kind of thing. So, Andre, take us through some of the very basics of these two malformations, hemangioma versus venous malformation, and sort of what we need to know, as well as percentages.
Sure. So the field of what we call vascular birthmarks or vascular anomalies is the other word for it, has both tumors in it and malformations. Those are the major subdivisions. So what's a tumor? What's a malformation? So the most representative version of a vascular tumor is the hemangioma, or some people like to call it the strawberry birthmark or something like that. Strawberry angioma, strawberry hemangioma. There's lots of different monikers for that particular birthmark. What is it? It's basically a vascular tumor that's not necessarily present at birth, but it shows up as a little tiny blush of red, maybe a little pimple that's red shortly after birth, whether it's a few days after birth or a few weeks after birth, and then it steadily grows in size. It grows sometimes quite big, and it could obstruct different things like vision or airway or the nostril for some kids. Otherwise, it's more of a limited lifespan type of a tumor. It is the most common tumor of kids. This is a very well-known fact, and it goes with a certain life cycle. What is that life cycle? Basically, once that tumor develops, that hemangioma develops, it will grow in size up to about a year to a year and a half. And then it will enter what's called the plateau phase, where there's no growth. It doesn't get bigger. It doesn't get smaller. And that can last for years, somewhere between 3 years up to 7 years. And then slowly it will involute. Involution is basically that the process of it caving in on itself and essentially eliminating itself from the body. And that's the life cycle of these hemangiomas, and a large part of them, you don't need to do anything other than watch them, let them go away on their own. However, there is a subset that you do need to intervene and do things for, and we can certainly talk about that. The other side of it is vascular malformations, of which, what you mentioned, venous malformations, is one of those types. What are malformations? Is basically a jumble of blood vessels. So they are on a microscopic level, they're just as normal of a blood vessel as any other blood vessel in the body. However, the body during development sort of conglomerated everything. They just jumbled it up into one little package, and it doesn't flow correctly. And so that lack of flow produces symptoms of increasing size, swelling, pain, even bleeding from these things can happen. And the difference between those vascular malformations and the tumors is that the vascular malformations don't go away. They don't have the same life cycle. You're actually born with them, and they can steadily increase in size, but it's not a tumor. There's a difference between a tumor and a malformation. A malformation never has the potential to grow beyond its boundaries. A tumor does. And so that's the main split to understand why does hemangioma go away and vascular malformation doesn't go away. Determines what you do for that child. Do you operate on that child, or you just watch the child? There's a vast range of treatment options.
Yeah, and I think that, again, back down to the person who's at home and their child was born with this. Some people are like, oh my God, that happened to my child. And as you said, the strawberry hemangioma, again, what people refer to it, the part about it that's pretty critical is that if you're able to not freak out, in the overwhelming majority of instances, it'll grow, stop, and then go away. And the other kind obviously requires some intervention, which we won't dabble in. But the bottom line is that these are quite common and they occur in children, and it's good to know. We're going to talk about one other quick one and then get into what I know is your area of super expertise. The other one is, actually, let's just dive into the super expertise. So I know that you have devoted a significant amount of your career to something called facial reanimation. Facial reanimation basically means someone, child or adult, but often you started this in the child range, is born with the inability to animate, that is, move parts of their face. So whether that be a smile, a blink, etc. And so the facial nerve, the nerve that is essentially the cables that allow us to animate all the muscles of the face, for some reason is non-functioning. And something that it seems like most people know, nerves don't just regenerate, especially motor nerves that take care of motor function. And so if they're not functioning from birth, or they're traumatized or cut or whatever, they don't just come back. And then starts the area of what you do, which is trying to figure out how the heck are we going to get this person to animate again, move their face, move their mouth, blink, etc. So that's the intro without getting too complicated, because we lose people if they're sitting on their treadmills right now, actually running on their treadmills. Tell me a little about facial paralysis and, break it up into, congenital, traumatic, etc.
So facial paralysis, it really has to deal with the function of what's called the facial nerve. We call it the seventh cranial nerve. We have 12 of them in our body, and this is number 7. So number 7 comes out from an area just behind the ear, right in this little crease behind the jaw, and it goes right into the cheek and starts to branch out to the various muscle groups in the face. So things like smiling gets more than one branch of that nerve. Forehead elevation is another one. Eye closure, the ability to move and articulate with the lips, even the ability to flare that big giant muscle in the neck is related to the facial nerve. So when we talk about facial reanimation, we're talking about restoring some movement in those muscle groups that have been damaged or their function has been lost, specifically related to those muscle groups. Now, there is, as you mentioned, a difference between a congenital facial nerve palsy or a congenital facial paralysis and someone who is traumatized or has Bell's palsy, which is a very common reason why people get paralysis of the face. There's vastly different clinical appearances. So in the setting of a child who was born with some part of the facial nerve not working, well, the problem is that nerve never developed, or that branch of that nerve never developed, and therefore that muscle never developed. And therefore the interventions that you have for someone with a congenital facial nerve palsy versus someone who had it traumatized or cut are going to be vastly different. You don't have the same tools.
Let me reiterate that for a second. So as a child, if you're born with a facial paralysis or something wrong with your nerve, the end recipient of the nerve is the muscle. The nerve is there to move the muscle. And so those muscles invariably are not either well developed or developed sufficiently. So when you go to fix it, you can't just hook up a new nerve to a muscle that doesn't exist. If you're an adult and your nerves have been working all your life, adult meaning anyone who's already developed, and then a table falls on you and cuts that facial nerve, the muscles were there. They just have no nerve that goes to them. And so that's going to dictate essentially what you do to reanimate the face, correct?
Yes. The ways we reanimate the face can be divided into bringing in a muscle or bringing in a nerve to where the problem lies. So when do we do what? It depends on what the underlying cause is of the facial paralysis. That's number one. So for example, in a child who was born with, let's just say the smile isn't working, we don't necessarily bring in nerves because there's no muscles to attach to. So we move a muscle into position that will take over the function of smiling, for example. And there's various muscles that we can use. When, for example, if it's an adult or a trauma patient who has the nerve cut, sometimes we can do what's called a nerve transfer, where we actually bring in a nerve that's adjacent and working and feed it into the one that's not working, which is the facial nerve. And by way of splicing it in, just as you would like any electric cord or something like that, where you're repairing a damaged segment, this is exactly what we're doing. And we're delivering a slightly different impulse into that facial nerve, which has some implications for rehabilitation, but it ends up salvaging those muscles that are responsible for smiling, for example.
It's nothing shy of incredible. I mean, if you don't think medicine is incredible, I don't know what to tell you. I'm still in awe of all medicine. The fact that we can give you insulin in place of the fact that you don't have it and you survive. I mean, there's incredible. Then you add surgery and you're basically taking a human being, you put them asleep and you arrange crap and then they come out alive. And then you get higher and higher. And in my opinion, facial reanimation is up there with like transplant and things like that. It's just so incredible that we can rearrange the face utilizing tools in order to bypass functional abnormalities and get them to work. And the ramifications is incredible because what you're fixing isn't an ear that's too big. You're not fixing a nose that's too big. You're fixing something that without it, I would dare say your life is ruined. If you can't move half your face, you're just non-functional. It isn't like, oh, wow, I got this horrible scar on my forehead. That's terrible. This is even another caliber. So I am always in awe by what we're doing in plastic surgery, and more importantly, as we push the envelope. And, maybe I'm a plastic surgery geek. And so I find this subject matter so incredibly interesting. But I assure you, when we talk about to patients, they are always blown away by these aspects. It isn't just breast aug and tummy tuck and rhinoplasty. All amazing, all necessary. But these areas of plastic surgery are also incredibly crucial. And people like you, who dedicate their lives to doing things that are so particular and so specialized, are so valuable, because at the end of the day, it's easier for you to go and do a breast aug, and arguably financially more lucrative than taking a child and spending 5 hours and reconnecting muscles so that child can smile. And I don't know if everybody really grasps that. The lay person doesn't understand what we assign as value. We assign value for our healthcare.
Right.
We think that breast aug is valuable, so you spend $10. Facial reanimation, by that standard, in my opinion, if a breast aug is $10, facial reanimation should be $50. But it's like $2. Right. And it's just mind-boggling to me that that's how we prioritize. You pay a scientist in a laboratory $50,000 to find a cure for cancer, and you pay LeBron James $175 million to put a leather ball through a hole. And we just, it never ceases to amaze me. Andre, thank you so much for coming on and, sharing some of your gifts with us today. And if anyone knows of anyone who is in seek of guidance in terms of pediatric plastic surgery, Dr. Panossian does a host of other things, hand surgeries and things of that nature. Where can they find you, and where are you about?
Sure. Our offices are located in Pasadena, and the easiest way is to just go to the website. It's drpanossian.com. That's drpanossian.com. And you can obviously, if you're interested in a consultation, fill out the contact form. One of our coordinators will reach out, make you an appointment, have you come in, and we'll go from there.
By any chance, are you Armenian?
I am
Dr. Panossian. I think you are Armenian. I am
most definitely Armenian.
Dr. Panossian is my connection to the Armenian Brotherhood.
That's right.
Brother,
we got to get back to Armenia.
I do love you, and I do appreciate you, and I appreciate you in many ways. And your skill and diligence and expertise is always refreshing. At any rate, that wraps up another episode of Plastic Surgery Uncensored. As always, I'm your host, Dr. Rady Rahban. I hope you enjoyed this segment. As you know, it's crucial that you tell your friends and share the podcast so that we can continue to grow and provide what I feel is really crucial information for those of you who are interested in this field. Until next time, tune in. Have a wonderful day.
Thank you for listening to Plastic Surgery Uncensored with Dr. Rady Rahban. We would love your feedback. If you enjoyed this episode, or if you find our podcast helpful, tell us why. Leave us a review and make sure you subscribe on your favorite podcast platform. If you have a topic you would like for us to discuss in an upcoming episode, please reach out to us on Instagram at Dr. Rady Rahban, on Facebook at Rady Rahban, or at RadyRahban.com.